Hi, this is Sophie. Obviously, I don't know why I said that. So I'm going to go through chapter 8 and 9 fairly quickly. A lot of this is going to sort of seem a little bit redundant, but it shows how important therapeutic relationships are. So just listen to it again. It takes our brain to hear things multiple times to really sink in. And I really want these concepts to sink in for you. So again, same kind of concepts we've been talking about. The nurse-patient relationship is our primary relationship we're discussing. Really, the most important factors is you need to have boundaries. That is so important. We've talked about physical boundaries in our clinical sites, but as well, you need to set appropriate boundaries as what people talk about too. And if a patient is talking about something inappropriate, you need to set those boundaries. There needs to be a safe, confidential, reliable, and consistent. So, in order to build a trusting relationship, they need to feel that you are consistent in how your behavior is. Patients can be very inconsistent, and so we need to provide that consistency. So, the therapeutic use of self, this is one of your test questions, and you may see it again on your next test. But really, it's how you find a way to connect with a psychiatric patient. And so some of it is an awareness of, it talks about having that full awareness and personality. It's having awareness of what you say and share. So you want to be very thoughtful in what you speak and what you say. So sometimes we can have flight of ideas and go off on tangents and kind of keep talking. In a psychiatric kind of relationship, when you're trying to therapeutically communicate with someone, you really need to have an awareness of what's coming out of your mouth. And one way to do that is to listen and to be thoughtful and purposeful in your speech, so that you stay on topic, that you are listening to what the patient says and letting that guide what you're saying, and that you can try to incorporate your nursing interventions. So that's that idea of use of self, and it's a little bit of an obscure concept, I think, to wrap your mind around, but it's the way that you use your abilities to communicate to therapeutically help and communicate with the patient. So here we go. Everything that I was just talking about. Why do we use therapeutic communication? To facilitate communication and try to get a patient to talk about their thoughts and feelings, help them to problem solve, help them look at some of their behaviors and what they can do to change those behaviors, help to promote self-care and autonomy. Those are all reasons why we have therapeutic relationships. You're looking at the needs of the patient. You are setting clear boundaries. And that's, a big boundary we set in my group, which is therapeutic communication with a group of people, is time. So my support group that I run runs from 10:30 till noon. At about 11:50, I say, we have 10 more minutes left. Is there any pressing thoughts you would like to share prior to we end at noon? So I give sort of a 10-minute warning for anyone to get any kind of pressing thought they want to have out, but I also set very clear boundaries from the beginning. So from the get-go, I let our group know we end on time. And I would say I try to do that in class too. I'm a big important that we adhere to boundaries. And it's very important in therapeutic relationships because a lot of these patients are struggling with boundary issues. So these are all kinds of things that you can do. I'm not going to read them all to you. This is sort of saying the same thing again. You need to have clinical competence and know what you're doing, right? This is the kind of thing that it's important you practice, and this is why we talk about it so much. The focus is on the patient's needs, not yours. So like I've said before, if you're bringing your own stuff into it, you need to step away. And at times there may be patients that are just, for whatever reason, it hits too close to home, and maybe that's a patient you don't, or you communicate that with the team that for whatever reason you're having a hard time maintaining boundaries, you're having a hard time focusing on the patient's needs. It's important to have accountability and to take responsibility for your conversation. So if someone were to express suicidal thoughts, you need to follow through with what you need to do to help them. And you really, really, really want to delay judgment. You want to make sure that even if someone tells you something shocking, work on your facial expressions. I tend to show how I feel on my face. So you need to be conscious of it. It's a very purposeful type of communication. It's not a type of communication. Therapeutic communication isn't this sort of easy flow back and forth and see where it goes. Ideally, it feels like that, but you want to be very thoughtful and purposeful in the things that you're saying and to really listen. Again, we've talked about this. Physical boundaries, we've talked about the contract means what you establish in the beginning. We're going to talk for an hour. If you're at a therapist and ding, 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 your bell is up, they'll say, hold that thought. The only time I ever would discuss boundaries with a patient is if I really don't even let them finish their thought, to be honest. I give a 10-minute warning, and then I really say, I'm so sorry to interrupt you, but we need to end on time, and it's 10 o'clock. I'd love to hear the rest of this at the next session. And I don't stay after and talk. My coworker or co-leader used to stay after, and she'd be there for an hour talking to people. And I said, you can't do that. You got to establish boundaries. So setting the contract is so you set clear expectations from the get-go. Personal space is important. As we saw in clinical, some people, especially if they're schizophrenic or having delusional kinds of thoughts, their idea of personal space may be a little bit skewed. So we want to help set those boundaries. Also, when it comes to personal space, think about how you talk to the patient. Do you, and we're going to talk about that in a little bit, but do you sit at the same level? You don't sit them face on. Possibly you put your chair at, 180 degree angles so that's a little more comfortable sometimes. Remember in psychoanalysis, that's where the person would lay on the couch and not even look at the therapist. We've sort of moved away from that, but that was that like traditional psychoanalysis kind of how they would have a therapeutic relationship. It's very important not to blur boundaries. So you really cannot socially mingle with someone who you are counseling. That is a big blur of boundaries. I have a friend who's a therapist, and people ask her things all the time. And of course, she'll, talk here and there, but she will not see anyone she knows as a client. She'll refer them to other people because it's too difficult you really want to be impartial, and you want to be able to provide an impartial response to a patient, and it's very hard to do that if you have any other connection other than the patient-nurse relationship. So, someone comes into a inpatient psychiatric unit and it's your neighbor. That would not be an appropriate patient for you to take care of. That is blurring boundaries. Another example is if a nurse is meeting her needs at the expense of the patient. So the patient talks to you about loss of their father, and instead you spend an hour talking about how when you lost your father. That is blurring boundaries. You have to be very aware of your own stuff going into it. And while it's okay to share a little and then redirect, that's sharing of yourself, right? It's using therapeutic self, but at the same time, a therapeutic relationship is not a two-way street. It is absolutely not. You are providing their needs and making sure you're providing to care for their needs and trying to meet their needs. Bye, Lils. Blurring of roles. We've talked about transference. This is when maybe the patient is mad at their mother, and instead they tend to then be mad at you. So I feel like you see that through authority a lot. My teenagers do that. They may be frustrated with a teacher at school, and then somehow that turns into them being frustrated with me. So you want to just be aware of that, and you want to call it out if you see it. It sounds like you're angry with me, but what I'm hearing is that you're feeling frustrated with your mother. Do you want to talk about that? No, that would be yes, no. Do you want to explain to me why you're angry? How about that? Is that still yes and no? How about tell me about why you're angry with your mother? How about that? I like that. See, it takes a lot of practice. Countertransference, this was a test question for you guys. It's the opposite. It's when they gave the example in your test that maybe someone reminds you so much of your grandmother, so all of a sudden, sorry, my kids are being really loud. All of a sudden, you feel very close to your grandma, close to this patient, and maybe you're letting boundaries get blurred because who they remind you of, and that's that countertransference. Very, very important to be aware of your values and beliefs as well as your patients, and to think about how culture can influence that. So we've talked about this a whole bunch. I'm not going to go in anymore. Peplo we've talked about before too, and Peplo was the theorist that looked at nurse-patient relationships, and she said that you have this orientation phase where you get to know each other, and then you have the work where the work is done, and then it needs to terminate. And sometimes patients will make up problems because they're afraid to terminate. And so it's really interesting. It can be very hard for patients to let things go or let a therapist go or a therapeutic relationship they have with a nurse go, because you get to feel close to them. And I feel like that in my support group. Some of these patients, I really do get to feel somewhat close to them, but you need to terminate that phase. A healthy therapeutic relationship ends eventually once that work is done. And so, obviously you can read all this, what happens during the phases. And the idea is, from the get-go, you set those boundaries. You set the contract, you set the terms so that no one is surprised. We will talk for the next 6 weeks. After 6 weeks, hopefully we will reevaluate and decide if you still need to continue with therapy. What are the terms? You may have a therapist who moves. And I have a friend who's a therapist, and when she moved, many of her patients felt personally offended that she was abandoning them. So it's almost, you almost want to set the get-go from the start that, if for some reason at some point I'm unable to meet with you, I will have these referrals set up who are absolutely capable and, competent to do that. Working phases, when you actually get the work done, you're really looking at things. And Peplo would say you can't do that until you've established trust. And I think Courtney kind of mentioned that today in when we were practicing support groups, that first question about the hardest thing you've ever been through was probably hard for some people if you didn't already know each other, because you really do want to establish that trust first. And so I'll let you read that. This is what happens during the working phase. And the termination phase is you're done, right? It's time. Goals and objectives have been achieved. And this patient is going to go on and incorporate these new coping strategies. And maybe they'll do a check-in once a month or a check-in once a quarter. And you can reflect on this relationship that you had. But a therapeutic relationship needs to come to an end at some point. And these are all things. Pacing is a perfect example of not jumping right into that working phase to go ahead and at first establish a relationship during the orientation phase. I cannot stress enough how important it is to listen. This is not a two-way street. I'm going to say it again. You are listening and the patient is the focus. So it is so important that you stop and listen and you are purposeful and measured in what you say. Again, trust is huge, and that was one of your test questions as well. Being genuine. Patients can see that when you're not genuine. And sometimes looking at the words you say, empathy is a little bit different than sympathy. A lot of people don't want you to feel sorry for them. They want you to acknowledge that what you're going through is hard, but they don't want to feel pitied. And that's kind of that difference between empathy and sympathy. Empathy is that idea of trying to walk in someone's shoes. And, we can't really ever truly understand what someone's going through. So these are all things that promote growth. So really withholding your own values and judgments from the patient, understanding that we believe in autonomy and that it's okay for patients to have different ideas and values than you, and really not even to share your own. Again, it's not about you. And we want to really help set patients up to develop resources outside of just that relationship. The goal is to get them to be autonomous. The goal is to get them to get to that termination phase. So that's it for this one. I am going to work really hard to turn this off appropriately this time. But of course, it's not going to work that well. Okay. Oh my gosh, what is wrong with me?